any kind of problem, if taken through the motivational interview, things can change. And I find that that's been really helpful to a lot of people that I've talked to. You know, a lot of times they'll say, I just thought I was going to come in here and get my ankle checked out, and you know, here we are talking about something it was just on their mind. So it's a good community service, I think, as well.
I've also had a lot of patients who say it's a great thing, you know, for us to ask these questions because they know our community needs it. We need to find those people that need the help and give it to them. So they like to see that our community has this kind of program.
It works. Like, I think that was what was so cool about us. Like, we weren't really sure how this was going to work because we work with a lot of addiction patients already, but is that all we're going to find? And then like day one, we have a community patient that has some issues and we're like connecting with Tom, we're like, it works.
People respond differently when you ask an open-ended question versus a yes or no, you know? And that makes a big difference just in getting them to open up and talk about whatever their needs are.
It really has. It's opened the door for more opportunity to incorporate the behavioral health specialty into primary care and vice versa, gain our confidence in that arena, and I mean, we wouldn't be where we are today without the SBIRT opportunity.
The ED staff, I think, you know, one of their barriers was, what are we going to do if someone comes in and says, you know, I'm depressed, or if we find out they have a high score with alcohol use, you know, what do we do? And I think it's one of the benefits is that it helps them realize that you don't have to have this huge complicated treatment system or program to intervene with someone right there, right? You can have a simple conversation with somebody and it's really, really effective.
I think it opens up lines of communication. Given where we are, I think there's a high incidence of addiction, a high incidence of alcoholism, high incidence of depression and mental health issues. And so just being able to add that extra service into their visit probably makes a big difference on their overall health.
You might not have all the pieces in place, you can still get going with it. And look, it just helps people. It just does.
Well, when I walk into a patient's room, I introduce myself, of course, because we're not, of course, like your average medical center. We have the holistic approach to healthcare, and which includes your mind, body, spirit. So we want to make sure that everybody is taken care of. So, of course, when I walk in, I introduce myself because it's not natural if you're coming in for an earache to see a social worker. So,
you know, over the last few years, there's been a bit of a culture shift, or at least an attempt at a culture shift to get people to view mental health and substance use as, you know, part of the whole person, right? And so they're not these separate entities, and the people are not viewed as, you know, oh my gosh, it's those people, right? Those people with addictions, those people with mental health problems.
So going in, I just introduce myself and make them aware that we have behavioral health services here at the agency, and that we, you know, are interested in making sure the whole person is being treated when they come to our agency for services, that we're not just focusing only on medical, that we also look at mental health and you know, whatever needs that they may have that we can help them with. So just, you know, looking at the whole broad picture of the services that we offer first with them, and then kind of zeroing in on how we might be able to help them with whatever's identified through the SBIRT screenings.
The patients here are offered what I call a full person care. That care addresses things that go from dental all the way to every and any medical issue that they could come in with for physical health. Then when you add in the screening for the SBIRT and the GIPRA program, that allows us also to capture any drug abuse, alcoholism, and or any depression as well, or mental health. We also offer services here on site for therapists on hand, as well as AOD counseling and grief counseling.
Well, if you don't help people deal with their stress and anxiety and all those kinds of things, you're really only treating half of them. if that much, because people are complex, as you know, there's the whole mind, body, spirit, and all that kind of stuff. And if you're only treating that one part of it and not, talking to them about, well, why is it hard for you to take your medications, or, how come, you don't try to do something to change your situation if possible, then you're sort of shortchanging them, really.
If they just have primary care and you add that behavioral health aspect, then you are going to be offering to help the whole person. They come in with a medical problem, but then they see, oh, they care about my whole person. They care that I might be depressed. Instead of just, writing me a prescription, they're going to send me to a therapist who can help assess the whole situation and can start helping me. So a combination of medication with therapy, you're just going to be hitting it from both angles.
Once you get them here and they're in an environment that they know that they can come here and get services from whatever aspect of their health that they need, makes it easy, because all they know is they just need to get here, and then we can hopefully take care of them.
So that's another piece of it is actually trying to achieve that culture shift. So once you have the program up and running, that's what the nice thing about SBIRT is. It's very kind of very non-invasive way to actually get in the service lines and show how those three areas can they do actually blend together, right? The physical, mental, and chemical substance abuse realms.
Yeah, I think everybody learns more about the patient as a whole because of this process. There's staff is talking to each other more because of this, because they're forced to because of the workflow and the small environment that we work in, but it's a good thing because it's helping the patient. So yeah, I think it's improved staff interaction, it's improved our interaction with the patient. I think people realize that we have a service kind of unique than others, because before I don't think people realize I can go to my doctor and I can talk about my diabetes and things, but I can also really talk about depression right here, and it's all in one place.
Patients coming in to get, shoulder looked at or a foot fixed or something like that, and then finding out, oh wow, you offer these other services or opportunities. Yes, absolutely. As I stated before, we're here for the whole person, not just one particular thing. Having patients having experiences with their primary care physicians in other places where when they open up to them about grief problems they were having, depression problems, unfortunately that provider at that particular location just told them, well, deal with it. So that caused them to basically not get any treatment, including for their diabetes and other mental physical problems, including their depression, for over 3 years. To coming back and then coming in here for something completely not related, and then get an opportunity to meet one of us to work with them and help them find counseling.
It's just a different way of doing things, and I think that holistic approach is just so crucial to people's care, because I have found, and research has shown, that medical and mental health, they go together. Physical health and mental health go together. If oftentimes your physical health is bad, then your mental health is gonna go, you're gonna get kind of down in the dumps a little bit about it and struggle with that, and vice versa. So if you have mental health, you don't often take care of yourself physically. So offering all of that under one roof is I have seen that it has really helped people, which has really encouraged me to even enjoy it even 10 times more so.
And I love, being a behavioral health therapist, I love the fact that it's hitting the whole person. You're dealing with the health issues upstairs, and then seeing if there's any depression, or in the behavioral health we add an anxiety questionnaire, we add a mood questionnaire regarding bipolar, and then of course the alcohol and drug. We're hitting every aspect. You can't go wrong with SBIRT.
That doesn't mean to say that that's the only thing that you focus on, but people are not scary. They are messy, and it can be difficult at times. However, I think that by having the SBIRT system in place and the ability to address depression, alcohol, drug issues, you're going to benefit your patients more in the long run, even if it seems difficult in the short term, especially for you in terms of what you get into. You start asking those people those questions and they get difficult, it gets messy. But don't be afraid of the messiness.
Patients just realize it's a part of the process of going to the doctor. That they ask about this.
Makes sense, yeah. It's
Treating the patient as a whole.
Yes, we're treating the patient as a whole.
Holistic care over here. I think people will be impressed by what it can do for your practice, for your staff, for your patients. I know this sounds kind of corny and funny at the same time, but like it's brought, like Tom and I probably wouldn't have the relationship that we have if it wasn't for SBIRT. We're fond of him, you know what I mean? It brings some staff together that probably wouldn't have communicated as much or on a level that they do. So I think it helps us become a tighter knit staff to better serve the patient. Does that make sense?
Everyone's very excited to have me a part of the program because they feel like it's a big asset for them to have someone, assessing their patients' needs and really caring for their mental health as well as, when they're social, like alcohol and drugs as well.
I think there's a little more communication in terms of what the client needs, sharing of information. So yeah, it's definitely helped us move toward more integration in our services instead of like they do their thing and I do my thing.
It has opened the doors a little bit, a lot. Different people I think have different thoughts about that, but it definitely has opened the conversation with behavioral health and medical services being integrated, which is great.
If they know that these questions are coming and they know that they can come here and they can get the help without being judged, and we have resources and they know that when they're ready for help that we got them, we can do it.
Lots of people they have shame associated with their use or their mental health difficulties, and just talking to people about that doesn't uncover a huge can of worms from the provider side, and from the public side it helps people understand that it's okay to talk about these things.
Well, any of our patients coming through for healthcare are screened by the RNs, and then depending on how they score on the SBIRT, they could be linked. I could be asked to go in to meet with them and offer them services based on the outcome of their screenings. And definitely have seen an increase in our behavioral health numbers being served here as a result of the SBIRT screenings.
A lot of folks that have been hospitalized because of an overdose, and it's an accidental overdose. And when they finally come to and they're medically stable and able to kind of realize the gravity of what just happened, having SBIRT there to talk to them and get them engaged in services right there, having a therapist up in the patient room before they even leave the hospital, and getting everybody linked and getting them comfortable with services, because coming into a facility is very scary, and a lot of these folks have never been into a facility, an outpatient facility. They don't know what it is. It's very stigmatized and they do not want to have anything to do with it. But meeting people that are going to be there and getting the ball rolling ahead of time has really created a lot of success with people coming out of the hospital and getting an appointment and getting started in services and working on getting sober.
The training was definitely beneficial. Before I started, I had no idea what was going to happen. No idea, and I had assumptions of my own about what I was going to be doing that were completely wrong. I didn't know about the specific tools, the motivational interviewing that we were going to be using in the brief interventions. It was definitely really helpful because I had no idea what to expect initially.
Getting to do the motivational interviewing and having to do that on a regular basis, I think has been really helpful for me to develop that area, which is a big area in counseling and in my field. and my discipline. So it was a good opportunity for me to practice that a lot.
I think that I've become like more confident talking to people in more kind of sensitive areas. I mean, it's hard to talk to a person who has a drug problem, you know, and asking all those personal questions. And I've always loved talking to people, but sometimes you kind of, you know, tiptoe away from those harsh areas. And I've just become more confident talking to people, and, you know, I'm learning things every day about the medical profession as well. I'm learning terminology, I'm learning, you know, everything, like the whole doctor's office, like when a person goes in, the kind of questions doctors ask, how they coordinate their care, you know, all of that stuff. I'm learning stuff about x-rays, you know, I'm learning everything about medical field that I never thought that I would have. So it's really given me knowledge, and I'm excited about it. It makes me want to learn more.
It's given me a new perspective regarding alcohol and drug. Even though I have a LISW, I've just never dealt much with alcohol and drug patients, and it has kind of opened my eyes to the process, what's going on out there, the addiction loop that people get caught up in, and they need help. You know, I'm sure that that first time that they used, in their head they probably thought, oh, I won't get addicted. Just one time, I'm just gonna have some fun. And the next thing they know, they're caught up. And we're all human, we all make mistakes. We need to help them get out of this loop. So it has really opened my eyes to that.
Well, the MI skills are like valuable. I'm taking classes during my master's in social work right now, and actually a whole class dedicated to MI, which is great for me because, you know, my instructor loves me. I can give real-time examples, and but I think for anybody who's in any healthcare profession, those skills are the most valuable you could probably get.
I feel like I've learned a lot about, you know, people's mood, drugs, and alcohol. Coming into it, I was a receptionist for dental, so it was completely different for me. I didn't really know much about any of it. So going in and talking to these people and learning things, you know, they'll say things like, you people have no clue what it's like to be an addict, and I don't. But hearing their stories and things that have happened to them, I've learned so much about addiction and depression and stuff like that.
I feel that it's been a really big education in empathy and being understanding, because a lot of times there's a big stigma against people that use alcohol or drugs, and when you go in, you can't have those assumptions anymore. It's learning that these are people and they have stories and they have reasons why they use, and just listening to what they say, you learn a whole lot about empathy and about understanding people.
I think I definitely have become more qualified to work with people in a broad range of different stuff, as far as, you know, the mood, the drugs, the alcohol. I mean, there's so many, it's a huge spectrum. So to be experienced in talking about all of that stuff and be comfortable with it is probably, I mean, plus you get to help people, so.
So far, we put it in emergency room settings, and actual space for the person to do it has been the first barrier.
It actually has been working okay. When they brought on students and then hired people to come help us, that helped a lot, because as much as we would love to have our behavioral health social workers run up here all the time, it really doesn't work well for them or for us, and it just doesn't work well. You can't everybody do their job and timely flow that when we only have a few rooms per provider. If you had extra rooms that were dedicated to the behavioral health staff and that patient to go to that room while they're doing that, that would give us our room back. That's probably been the major problem.
My boss was very good at being that person that went in and explained. He advocated real estate in an emergency department is fairly precious, and he went in and got us space and got us materials and things.
The biggest barrier there is trying to work it into the actual workflow, right?
Well, anytime that you take time away from getting patient to provider, that affects your daily flow and your response time and those kind of things. However, given the scenario, how we have it set up now, I think it just flows along with it. So it's just another step, like if you were going to triage a patient, or there's certain things that has to happen before you get a patient, and that's kind of incorporated into it now.
The second barrier is, well, who's going to pay for this, right?
There'll be a lot of people that might test positive on their pre-screens or their full screens, and then they have an issue with, well, I don't know if my insurance covers being able to see Tom or see the specialist to work on my depression issues. And so some might not have insurance, some might be underinsured, some just might have questions that they don't know how to actually ask their insurance provider, that I can kind of just go in there and be kind of the third person to do. So that's kind of nice to be able to tell somebody, yeah, you actually can get these services and they're not going to be a cost, or how can we work this so it meets your budget but yet also meets your behavioral health need.
For us, this is not a short-term project that we're doing to get some grant money and then we're just going to go back to business as usual. We're going to continue to, keep the system in place because of the value of it and the way it helps us to, operate our practice here.
The third barrier is, how are the patients going to feel about that?
It's a change. The patients aren't too bad. Some of them were really mean for a while about the papers, and we're just like, well, don't take it personally, we do it to everybody. And usually if I talk to them for just a little bit and say, well, you can't say that substance abuse, mental health, depression is not a big thing. You turn on the news and you can easily find where somebody has killed themselves, overdosed, went in and shot up a bunch of people, and can't say it's not a problem, so we're all focusing on it. And I said, maybe you don't have a problem, but somebody does out there, and by bringing it up, they're more likely to say something.
It depends on the patient. Most view it as just, additional information, just along with the other questions. It kind of feels like it goes right along with that. Some have been a little bit resistant, especially when things are a bit more personal. They don't really understand how it applies, and I try to explain, this is new, this is research that we have to do so we can continue to do this. But for the most part, people seem to accept that it's just part of the process.
But when it gets down to the nitty-gritty and you have to ask people if they're having suicidal ideation or homicidal ideation, that kind of makes it a little uncomfortable. As far as, do you have any medical problems as a result of your drug use? Have you ever harmed anybody because of your alcohol use? So those were the tough parts for me. The rest of it was pretty easy.
I have had patients where it was just them, and I was asking them these questions, and they're like, why do you need to know that? And so I kind of, just revert to the fact of, remember, this is, research data collection, and we're trying to, understand, different scenarios. I go, and all you're doing is you're just helping us figure those scenarios out. And then they seem to work out and are fine with it.
When you have to ask about sexuality or questions like that, they're a little resistant, but I just let them know, it's for demographic reasons. They don't have to answer them if they don't want to. They're allowed to refuse. So that makes it easy when you can tell them that they don't have to, but it's just for data collection purposes. They're okay with that.
I've had a lot of kind of, not upset looks, but just confused, like, why is this, why are you asking me these questions? And basically, I tell them it's part of your overall health care, It's important to know how you're doing in these areas for your overall health.
The fourth barrier is, well, what resources do we have if we ask people about depression and alcohol use? How are we going to actually deal with that?
Maybe resources would be one challenge, because I think that we're in such a small community that resources are kind of few and far between, and we kind of use the same ones because there's only a handful of them. But the great thing about that is that the resources that we do use, they have been very open to us, and because I'm the one calling for those resources, and so they've been very kind and generous to our patients and understanding what kind of our role is. So they have worked really well with us, which is a really good thing. But the lack of, there's only a certain amount of resources that are available in our community, so I think that that's probably would be the only negative I can think of. But we push through it, and I think our community has been really open to it, so that's been a real blessing. So.
Well, we have a lot of different agencies that we partner with as far as providing services, and because I don't do, for instance, drug and alcohol treatment or assessment, we've invited agencies who do offer those services to come in and give us some information about our services so that all the staff is aware of the services that are available in the community. And for some situations, it's more appropriate for people to go elsewhere for counseling services as well, even though we do offer that in-house. It depends on the individual's needs, where they live, what they're looking for, the type of treatment that they want. And so we want to make sure that we're giving them what they need so that they can best benefit from those services.
A 22, 23-year-old came into the emergency room for a heroin overdose. He was brought in by an ambulance with the cops there. And, you know, when I approached him, you know, I let him know this is, the police had left the room, and he asked me if I was with the police, and I said, you know, I'm here for you. I'm not interested in talking to the police about what's going on with you. So when we set up the interview with him, he was at maybe a 5, and I said, on a scale of 1 to 10, how ready are you to get off heroin? He said a 5, and so I said, well, what would make this a 10? And he said, well, if I'm ever back in your emergency department, I'll know that I've got a problem. An hour later, he's back, and and I just approached him. I said, so you're back? I said, help me understand this. If I remember correctly, one of the things that you had said was that if you're ever back in the emergency department, you said that would be a sign for you that you maybe got a problem. And I asked him, just where are you at with that now? And he was like, well, give me the information. And I didn't get him in, the liaison did. But it was a couple hours later, his family was all on board. So we got him in. Yeah.
I think one of my favorite moments is when you get a patient that is defensive, and then the second you see them relax and you're together instead of, the interrogator, and they see that you're there to work with them, it's the best moment.
One client that comes to mind is a gentleman who was referred to us by Department of Jobs and Family Services because he clearly was not job ready and needed to either be in the jobs program or working toward becoming job ready. And what happened to trigger them to refer him to us is that when he walked in for their first meeting, they realized that he was extremely anxious in a setting with other people. He actually told the worker that he hates people, that he'd had a terrible experience dealing with people in his lifetime. And then, so they referred him over to me. We worked a lot on the trauma issues. He had a history of childhood abuse, a lot of trauma throughout his life, and he's now at a point that he's looking into, or he's actually beginning to attend classes for job readiness. So he's really made some good progress, and that's kind of exciting to see.
I haven't had any big ones, especially since a lot of the referrals that I've made, I haven't had a chance to see them again or hear back about them. But when I do make referrals and when people are really receptive and thankful for me being there, for talking to them, that's when I feel like I've had a success story. I haven't seen the outcomes yet, but just making that impact for them and making them feel comfortable that they've had someone to talk to is a huge accomplishment.
We had a couple come in, they were like 47 and 52, but both of them had been doing hair for like over 20 years, and they both said they had infections on their heart from using the needles, and so they both agreed that they wanted to go into treatment together. And so we have a lot of people who will come to the hospital and say, you know, we offer this, whatever kind of insurance they have. And so we were able to get them into treatment, and I actually was able to do follow-up because they had to be admitted into the hospital, so they couldn't go into treatment until, but I was able to talk to one of the nurses from the floor, and she helped get them into treatment after they were admitted. So even though we didn't get to do all the work in the ER, we still were able to get them in. So it's nice to have outside resources, because sometimes our resources in Cincinnati are full a lot. And so we have a lot of reps come in from out of town and help us get into treatment. We've been successful with her. I think we had like 2 or 3 instances where we've been able to get into treatment out of town, and that's helpful also.
He was just having a normal checkup at a doctor's office, and he is in the position where he has been working for over a year. He financially cannot really support himself, and it's really been bringing him down. He's depressed, and he just doesn't have the means to help himself. And I explained our program, you know, what SBIRT can do and our services out there, and he was very interested, you know, would love to meet with our SBIRT therapist. And when I gave him all the information, he told me, and he said, I feel better knowing that I'm going to finally get help. So that patient left the office feeling better because he knows that he's finally going to have some treatment, you know, get the help that he's wanted for a while.
There's one person that came in and she just point blank said, had it not been for that paperwork that you all had me do, that SBIRT, I probably would never be coming to therapy. But I saw that I did have depression, and so I thought, well, what could it hurt? And she's still coming to see me.
Today, actually, I had a gentleman who just got off the IC unit because he had a major heart attack, and he was a positive audit. And he said that he used to drink pretty much daily until he said, I'm done. That scared me. He said I was in cardiac arrest. I don't even know how I'm here. So yeah, we got him set up with some outpatient AOD treatment where he lives, because he doesn't live in Sandusky, but he lives elsewhere. But we got him linked up with that, and we got him some lists of AA meetings, and he's super willing and super wanting to, you know, get into the right path, and he was so happy and so energetic and very, you know, appreciative, and he kept saying, I thank you so much. This hospital's been wonderful to me. You know, I don't think I could have actually been able to do any of this stuff, and I wouldn't be living without you guys.
Well, you know, I've had patients where they've referred them to me, and the provider's actually quite frustrated with them because they're maybe non-compliant with their medications. They, you know, complain a lot, you know, you're not helping me, all this kind of stuff. And then then this one in particular, you know, she comes and talks to me, and you know, after a couple of sessions, she's agreeing to, you know, start, okay, well, maybe I do need to, you know, address my diabetes a little more, aggressively, you know, so she starts taking the medicine, and, you know, she starts asking about smoking, and the provider's like, really? You know, and then she comes back and does blood work and her A1C's lower. Well, imagine that, you know.
I was working in the ED one day, and one of the nurses came and said, I've got a patient getting ready to discharge, will you see them? And I was like, you know, I had a bad attitude, and I was like, they're getting ready to leave. I was like, what do you want me to do? I probably can't do anything. And they said, well, they're here for heroin, and they're getting ready to discharge them. They're medically cleared. And I said, okay, I'll go over and see them. And this guy was 36 years old. The last 18 months, heroin had totally wrecked his life. He lost his family. He's getting ready to lose his vehicle. Had lost his home. He's living with his grandmother, who was there, and both of his parents were there. And the family really wanted him to get treatment, but I didn't know how much this guy was really invested. And he said that he really did want to go to treatment, and you know, he was ready to do something about it. So got on the phone and made some calls, and you know, the right insurance and the right location with an open bed and all that kind of fell into place. So we were able to do door to door and able to verify that he got there at treatment in about an hour and a half, and checked in, and they were doing their assessment. And so yeah, it was really cool.
She had scored high on the mood screening, had stated that, you know, she had thought about harming herself and had harmed herself in the past, but she wasn't thinking of it at the time. And when I was able to call her back and say, hey, have you been able to follow up with the agency you were trying to get with? She was like, you know, you were so nice. Thank you so much. You really helped that, because she didn't want to talk to me at first. And then she opened up and was grateful for it.
Like when I work in the hospital, I've noticed several times being able to look people in the eye and really see them, and they know that you see them and hear them. And you know, being in the hospital is often scary, and you feel kind of like an animal sometimes. You get poked and prodded, but when someone comes in and they're just looking at you, you know, eye to eye, and you're a person and I care about you, that's an awesome thing. I really enjoyed that.
I had a patient, a mom and a teenager. The teenager received the screening, and she had answered thoughts of suicide, and the mom didn't even know. She didn't even, I mean, that's not even why they were there. I spent about 30 minutes with them, and they now come to therapy, and they hugged me, and we all cried, and it was great.
You know, my advice for people that are going to be doing this or implementing this or potentially looking at implementing this procedure into their practice, I think go into it with an open mind and with a thought that your position in that team of providers and healthcare professionals that are working with this patient, that you are a very important piece to that puzzle. And by asking these questions, you are diving deeper into that patient care than what maybe the medical provider is safe or comfortable or knowledgeable of. So you are providing a huge piece of that puzzle.
Now, at the end of the day, you just have to make a commitment to doing it, right? And you make that commitment because it is what works, right? You know, for too long, we've let people who have problems with addictions or problems with mental health be those people, right? And that's why we're in the mess we're in, right? So make a commitment to it, do it, familiarize yourself and your staff with what SBIRT is, and choose how you're going to implement it, right? For the grant-funded program, it's really, really effective to prove the concept via the in-house specialist model that we have now. Because like I said, it's very low risk financially, and you have people that are trained specifically in how to talk to people with substance use and mental health problems. But that will spread, right? Once you have the right people that know how to communicate with other providers, that's the key.
Patience in when you implement a new program, it doesn't fix itself overnight, and that you have to have individuals buy in and be committed to what you're doing and the reason and the rationale why you're doing it. I think that's a big hurdle, is to make everyone realize the purpose of it, and then see the response later on. Be patient to see the response later on down the line.
There's going to be a lot of changes. Whatever system you immediately establish, there's going to be a lot of changes. Be open to making those changes, and network and communicating both within your area of responsibility and outside of it. That's a huge thing when it comes to MAs and providers, as well as talking to other organizations outside of what you do.
But each agency is going to be different because of whatever system they're using. You know, we happen to use the EHS system, and I highly recommend typing up checklists to where it flows, and then you share it with your people, with the MAs, and the MAs run the providers. You know, the providers are kind of, you know, they're there, but the MAs are the ones that really run them. So it's important to type up checklists that they can just run through and know what they're doing. And so I highly recommend that. Get those checklists going.
Be patient with it. You know, when you first start, it's a mess. You're adding all this new stuff to your workload, and it's not flowing right. But I think once people do get the flow of it, it gets easier, and it's just part of their everyday. I mean, you don't even have to think about it. It's just part of your workflow.
Just be patient with your patient. I always do my SBIRT last. I go in and do everything else, so they're comfortable, you know, with me. Like I do like a little small chit chat if I know that the SBIRT's coming, and then I just like gradually slip some of these questions in. And then when I say, okay, well, you know, I do have a couple follow-up questions to ask you. If they refuse, then they refuse. But sometimes I don't get that many anymore. I've noticed, like, since I've changed my, I guess you can call it strategy on how I ask them, I have a better result that way.
I think the thing that helped me the most was, if you are new and they're already established in your location, to observe as many different people as you can. Just check out their style, try it out yourself, see what works for you. You can be really flexible in the way you deliver it, and even in different locations, I have different ways I deliver.
You have to be aware of what your limits and boundaries are. In other words, like, what are the kinds of things you need to, that you have the capacity to address in-house, and then what are the kinds of things you need to refer out, you know, because oftentimes, not oftentimes, but at times, we'll get people that are more severely mentally ill than what we're capable of treating here, and so we have to make a referral. And so you can't be everything to everyone. And you might do interventions, you might work with a person for a few sessions and then realize that they need something more than what you're giving them. And so having the flexibility to be able to do that. And then the patience to be able to let things play out. And what I mean by that is that the provider, you know, or the SBIRT process might refer someone to you. However, their willingness to engage with that might not be there yet. And so, you know, communicating with the provider is like, well, yeah, they do have these issues, but, you know, they're more at a, you know, contemplation stage of change, and so they have to, you have to be, you know, willing to wait for them to be ready.
You're going to make mistakes, and that's okay. I mean, there's a lot of stuff that goes on, and especially with the documentation. And so, like we were talking earlier, we have errors, and you fix them, you move on, and you learn from them. The best thing you can do is kind of learn from it, and ongoing learning, especially with the tapes and stuff like that, with motivational interviewing, is super helpful, getting that. And you see that throughout the time, you see that in your brief intervention, where you can actually get more out of people by, you know, actually using certain tools that, you know, are best for you, because not everybody is going to use the same questions or, you know, use the same verbiage as somebody else, but they might get the same good result. So
I try to get a feel for the environment. Is it tense in there? Is she going to be apprehensive with me talking to her? I introduce myself and usually just take it from there. If they're not giving me much feedback, I try not to pressure them into anything. If they don't want to talk to me, I understand. But most of the time it just takes them a little bit and they open up.
Well, being new myself, I'd say the best advice is to not get too scared because it does take time. It's really overwhelming at first, or that initial, getting in there and talking to people for the first time. But don't get scared because you do learn and you do become comfortable. You need to practice and learn from experience.
Because a lot of times I'm seeing someone for their toe, I'm seeing someone for their rash, and the next thing you know, it's all this, So it can really waylay you. I think the biggest part in being in this job, not just with the SBIRT, but working with other departments and working in this environment, is trying to be a lot more flexible.
So if your mission is to help patients and SBIRT is shown to do that, then making that argument from, hey, I'd like to implement SBIRT, and you're saying, why would I do that? Well, because it helps patients, right? And it's relatively easy to do, and it makes sense.
Just be yourself and be serious, but have fun with it, and just care for people. It's kill them with kindness. I guess I've had times where people are rude to me. Don't be afraid of that, because it's just one person, and you'll get through that. You'll get through anything, so.